Good afternoon. Thanks for joining us for our monthly Maternal and Child Health Research Institute seminar series. We have a very exciting program today with David Rehkopf and Stephanie Leonard, who are going to talk about data for social policy recommendations to improve child health and development. This is going to be a much needed resource development for you. So I'm really excited you're tuning in. And I think we'll have a really nice discussion about basically how to do this type of research. And so, but first, a little bit of business. Next slide. Just wanted to point out the monthly seminar series continues in the summer with an exciting seminar series as well in next month with our MCHRI Spark partnership, really highlighting the new therapies and products that are being developed for pediatrics and maternal and child health through our Spark Fellowship with Daria and Kevin Grimes. In September, we continue with Lawrence Prince about why some diseases only affect babies in terms of really genetic analysis. October then leads to Sergio Pasca talking about understanding human brain development, disease through brain assembloids. Really an amazing session. In November, we'll have our MCHRI symposium, which we'll talk about in a second. And then in December, Michelle Berry, who heads the Global Child Health Program, will talk about new developments in child health. Next slide. In November in particular, we have our fourth annual MCHRI Research Institute Symposium, which highlights the emerging concepts and therapies that are at Stanford. We're really excited about Kelly Moley, the Deputy Director of Reproductive Health Technologies at the Gates Foundation, talking about global priorities in reproductive health technology, highlighting a really global health session. And then we have 4 exciting sessions total. Dr. Moley's, as well as sessions in pediatric cardiovascular medicine, our science advances in diversity, health equity, and social justice, and then also groundbreaking research from the abstracts from our rising scientists. So you'll get an announcement for call for abstracts in next month. So please submit your abstract. We usually select 5 oral talks from the abstracts to present. Next slide. I wanted to thank our education committee, their tireless work. We also are starting to basically solicit applications from new members for our education committee. So if you're interested, please talk to Roxana or just email one of us and we'll have you join the committee. As always, we have a survey we'd like to complete after the talk, evaluating the session as well as any additional comments that you have. So thanks for filling that out and sending it back to us. And next slide, really, I'll just, to save as much time as possible, wanted to then thank Dave Rehkopf and Stephanie Leonard for our talk today. And so I just wanted to, David is the co-director of the Stanford Center for Population Health Sciences, associate professor in epidemiology and pop health. And Stephanie is an instructor in OB/GYN. And they're going to talk about data for social policy recommendations to improve child health and development. But I wanted just to point out that this type of data and resource is increasingly important and available to you, the listeners at Stanford. It also points out that this type of this data is really important for those that are doing more mechanistic studies in terms of correlation or in terms of testing many types of hypotheses at once using these large data sets, which the Stanford has really invested in. And so I'm excited to have David and Stephanie present today. So David, take it away.
Great, thank you so much. Appreciate the introduction. Let's get this going here. All right, does that look okay?
It's in presenter mode.
Oh, okay. Let's swap that. Is that
there you
better?
go? Perfect.
Okay, great. Thank you. So thanks so much. Appreciate being able to be invited to speak here today. And that's exactly right, what you said about the broad relevance of the data that we have at the Center for Population Health Sciences. So I do work in social policy, and it can be used for those purposes, and that's a lot of the type of research that we support. But also, most of our users actually use it for a lot of clinical questions and mechanistic questions as well. So these are a lot of data sources that are equally appropriate for those type of questions. My goal here today is really to introduce you to some of the data that we have, how it may be useful for your type of work. And then Stephanie is going to go into some specific examples of her research that illustrate how this data can be used for improving child health and development. So at the end of our session, and I'll talk for 15, 20 minutes here, and Stephanie then will as well. We hope you'll be, have some questions for us, but in particular that this is really an opening and introduction to use the resources that we'll point to look into more detail on our data, and then come ask us questions. If you have a particular research question, you're not quite sure what data might be appropriate to use, we're available to answer those type of questions. So briefly, I'll say I'm going to be talking about, and what PHS focuses on is this third type of data, real world data. So there's data from randomized trials, which we know is incredibly useful, from traditional cohort studies, which enroll people at a particular period of time, follow them up for disease. And then there's something that is now being referred to as real world data that takes data that wasn't collected intentionally for research purposes and repurposes it for research and insights from data analytics. And so I'm not going to argue here that one of these is better than the other. I think they're all complementary to answering the type of questions we have. But fewer people are using real world data. It's a bit newer than these other types of data that have been traditionally used for a long time by health services researchers and epidemiologists and clinicians. And so I think there's a lot more sort of new things that can be done and learned, in particular with real world data because it's new. So there's 4 main advantages I see to using real world data for clinical and population research questions. One is just the size of that data. Some of our data sets, for example, have 80 million observations, 80 million people in them that then are observed over time. So you're able to look at very rare outcomes, prescriptions that were given to a small number of people. You're really able to take a precision health approach because you can look in small subgroups of the population where you may see different effects, which traditionally you couldn't do in a lot of other data sources. So just the size of those data sets has a lot of advantages. As I'll show in some of these examples, for exposures that might not have a large effect, there may be a really small relative risk, you're still able to get fairly robust estimates for some of those kind of exposures. A second thing is just the breadth of data that's there in terms of exposure. So, all of the sort of prescriptions, procedures that are given, a large number of different elements in the data, which make these data sets useful for a lot of different kind of questions. The fact that there's passive data collection is an advantage in many ways. And so we know how difficult it is to recruit people for clinical trials, to get people to continue to fill out survey forms. There's so much selective response. There's so much cost involved in those that there's a lot of advantages to just taking advantage of data that's already there and is just passively being collected. And then the fourth thing, which I think is less appreciated often, is the fact that this is real-time data that's being updated continuously. So if there are policy questions, in particular for me, this applies to clinical questions as well, but if folks have sort of policy questions about relatively recent policies, how they're enacted, how those affect health and child development, those are questions that you can ask with real world data. And so, traditionally before this was available, I'd rely on things like NHANES or NHIS, which 2 or 3 years later would be available. In this case, because there's sometimes the lag time is, up to, we can get data within a few weeks. It becomes fairly complete within a month or two. We can really take advantage of that as well. So this next slide is the challenges of real world data, which you may notice is exactly the same slide, but just with the advantages replaced with challenges. So the data is many, many terabytes often. It's not something you can just download on your laptop. So there's more complicated sort of analytic pipelines that need to be developed. The breadth of elements sometimes can be overwhelming. There's a lot of missing data, the data that needs to be cleaned. There's a lot of things, like every data set, really, but it's sort of exponential with real world data in terms of how much needs to be understood about different data elements. The passive aspect is a challenge that requires sort of some different thinking. You can't go out and say, I have a question about X. I want to ask people this question. What's their response? You have to learn to use the data that's already there. And then the real time is, again, another sort of cost. The data needs to be continued to be processed and organized in order to be useful for research. So with those advantages also come challenges. But that's the point why we exist, or one of the reasons why we exist at the Center for Population Health Sciences is to sort of, we have a whole team of people. This is not a one woman or one man job. This is a whole team of people that really work on this data, make it available, and help support users with this data. So this is not just curating in sort of the data science way, but also, how do I access this? Making sense of the different variables in our data. And so, one of the things I hope, with my sort of limited time here is just, to talk about how to kind of find out more information about what's there and kind of learn about what kind of questions you can start asking us. So our website, Center for Population Health Sciences, is a starting point. And if you go click on data, what you'll come to is our data portal, where we have an overview of all the different data sources that we have. You'll notice this is a very small font. Maybe you have a giant monitor and you can see this, but there's 24 data sets that are tagged with children. So specifically that have children in them, if that's sort of the focus of your research. But overall, around 70 data sets. Right now, there's around 780 users across Stanford. Most of those folks are in Stanford medicine. So we do have a lot of folks that use the data, but we are interested in extending this to as many people as we can be useful in supporting their research. So again, I'll come back to this at the end. There's a lot more that we have than I'll have time to talk about today, but I want to focus on some of our data that's the most popular and most used, and this is medical claims data. So this is data that's collected as part of billing and procedures at hospitals and outpatient clinics. We have two commercial data sets that we support and curate. One is IBM Market Scan. The other is the Optum Data. And so if you go to our data portal and want to know more about what's in those data sources, you'll get something like this, where you'll have information about the elements that are in that, whether there's prescription data that's available, it's diagnoses, treatment, procedures. Some have prescription data, some have cost data, depending on your research interests. And so there'll be a button to apply for access. And then our web portal takes you through the administrative things that are needed to access the data in terms of having an IRB. Some data sets require an extra paragraph about what kind of study you're going to do to get approval. But this is more or less automated. The other thing that that we're really proud of, and that folks at PHS worked on for quite a while to develop, is being able to look at sort of a 1% sample of the data. So you can get a sense of like, hey, I'm interested in this particular procedure or treatment. How many of those for people of this age, for kids 12 to 17, exist in the data? So without having to download the data, without having to really go into the servers and analyze it, you can start getting some really important descriptives that are useful, both for preliminary data for funding proposals, but just also to get a sense of what might be possible in using the data. So one of the data sets that I'm particularly excited about, because it allows sort of environmental and social types of analyses, is the Optum Zip5 data. So a lot of these claims data sets don't have spatial identifiers because of the risk of identification. We have a particular version of the Optum data that has the zip code involved. And so what happens then, it's claims data, but this forms sort of the backbone And all sorts of environmental data can be overlaid by zip code by doing a linkage. And that's something that we can, if you have those kind of questions, we can also help support. And the Optum data is privately insured individuals in the US, around 80 million individuals, so a very large sample size. So this is an example of an environmental type of study that one can do with the Optum ZIP5 data. So it was my privilege to be a co-author on this. This was work led by a medical student, Holly Elser, that was recently published in PLOS Medicine. She's now at Penn doing a neurology residency. And she was looking at warm weather and acute care visits in patients with MS. So one of the things about claims data, and again, to differentiate, there's so many amazing data resources at Stanford, and there's just excellent support for doing work with STAR data, with Stanford patient data. But if you're looking something like differences in weather and hot weather, that's the kind of thing, okay, well, you probably need to get outside of the Stanford patient database and do something nationally. And so again, this is something I should have mentioned earlier, but there's sort of other resources at Stanford that of course we can point you to if you're not familiar with them for looking at Stanford patients. But what we focus on is sort of California data in particular, and then national data as well. So with this Optum data, you can look across states, look at differences in weather patterns, and then link that to the claims data. A particularly nice thing about using some of these data sources, as I mentioned before, is their large size. So you can see here something like abnormally warm weather. You're probably not going to be getting relative risks of 2 or 3 with MS-related visits. And so you have enough power to detect, small relative risks on the order of sort of just a 4% difference in risk with this kind of data. Other type of work, most of my academic work is on tax credits, work income, and child health and aging across the life course. And so I've done work looking at the earned income tax credit and birth weight. I've also done work looking at the EITC and changes in health when that check is dispersed in the month of February. So just to give an example of the difference in the type of work you can do now with this kind of claims data, I did this data, this analysis that was published in International Journal of Epidemiology a few years ago. It was using NHANES data. I had a sample size, once you restrict to people receiving the EITC who are eligible, I had a sample size of around 6,000 individuals. That there was only pretty large effects that I could detect with 6,000 individuals. I can move over to Optum. I'm working with Holly and another instructor in our department, Matt King, on this new analysis, where we're using Optum data on millions of individuals now to look at whether there's changes in preventative care and other types of procedures when people don't have those financial constraints after receiving a tax credit. So we're really able to, it's a slightly different research question, but expand on my original research question with some of these new types of data sources. So another type of data source, so those two things were commercial claims data. Stephanie in a minute is going to talk about Medicaid data, which is particularly important. And then has a larger span of the population, isn't restricted to people who have commercial insurance. One of the things that's kind of come up recently, and I actually just met with the director of our data core, Bella Chu, and myself met with folks in Colorado on Wednesday, and have just gained access to what's called an all-payer claims database. And so what states are doing now is consolidating public and private claims data from across their state. And so we have something like 60–70% of individuals with health claims in the state of Colorado now that we have access to for COVID-related questions. And so increasingly, this is so something that we have now, and I think increasingly in the future, we're going to start pursuing more of these all-payer claims databases, certainly in California as well, where a lot of our work is being focused. I'll shift a little bit. I've talked about claims data as being something that's particularly useful. Another type of data that we curate and make available to folks is electronic health record data. So again, the difference is here, there's ways to get the electronic health data from Stanford Healthcare. And what we've focused on is things that are outside Stanford Healthcare. So we've had a relationship now for about the past 2 years, I think, a year and a half, 2 years, with the American Board of Family Medicine, who have a prime registry of family practices across the US, where we are curating a research version of this data for use by Stanford researchers and people outside of Stanford. So this includes 5.8 million patients, and I just looked up, it was around 800,000 individuals under the age of 18. This is geographic spread all over the United States. It's sort of oversampled in more rural areas. And we have complete EHR data as part of our research version of this data set for Stanford researchers to use. So this is around 5.8 million patients, as I mentioned, around 58 million visits from over 3,000 providers and physicians. And so we have full notes, lab notes, medications, procedural notes, as well as sort of social history, lab values, and again, a number of different insurance, folks with different types of insurance that are included in this data. So just to give you a sense, one of the powerful things about this is the longitudinal data over time. So as long as people are still going to these practices, we have data on them over time. You have a number of people with over 100 visits over this time period, and a pretty good distribution of race, ethnicity in this data. Another thing we're able to do with this data is look at things. So we've been looking back at using this to supplement CDC's approaches to monitoring disease in the population. Again, because we can do this on a weekly basis, really real time. We've been working with the CDC now to use it for monitoring of COVID-19 going forward. So this has been a very quick overview. Hopefully, I'm sure it didn't, there's brought up hopefully more questions than answers. That was the hope here, although now Stephanie is going to go into more detail on a few different studies, which hopefully will be useful as well. But I'd say now I want to highlight sort of 3 types of resources for you going forward. One is going to our website on the Stanford Center for Population Health Sciences. You can scan the different data sets there, find more about them. If you have ideas for new data sets that would be really useful for your work, we always like to hear about that. We try to collect these from different folks who have different kind of interests and really respond to those interests. And then finally, for getting help. So we have a number of data docs that help get you into this. There's a Slack user channel. And then finally, folks at the data core that I showed earlier also have office hours, so you can meet with them, and also just reaching out to me directly. So there's my email. I think I'm the only Rehkopf at Stanford, so I should be easy to find. And please just send me an email directly about any questions that you have about using this data, the kind of things that you can do with this data, and I'd really be happy to talk more. So thanks for your time here, and now I can turn it over to Stephanie.
Great, thanks so much, David. Let's see. Okay, that's projecting okay? Great.
Yeah, yep.
Great, thanks. All right, hi everyone. Thank you so much for joining us. Along with David, I'm really excited to tell you about what we've been doing, especially I'm going to be focusing on some large claims databases, but also we've been using other databases that David described. And I'm going to be using an example of my area of focus right now, which is severe complications of pregnancy and childbirth. This is kind of an example of how these data sets have been used. So as many people likely know, the maternal mortality ratio, which is the number of deaths per 100,000 live births in the US, is the highest among all high resource countries at 17.4 per 100,000 live births. That's the most recent estimate from the CDC. And this translates to about 700 people each year in the country who die during pregnancy or shortly thereafter. And that's out of 4 million births. And it's often kind of said that this is the tip of the iceberg of severe complications of pregnancy and childbirth. And that a measure like severe maternal morbidity is a more encompassing outcome of severe complications that put someone at a very high risk of death. And severe maternal morbidity, or SMM, had kind of a lot of different definitions, and it still does, but the CDC put in some effort to create an index that could be used in basically any claims database that has ICD diagnosis and procedure codes. And then you can identify these conditions and procedures that you see here. And that's a very standardized now and consistent approach to identify SMM. And as I kind of mentioned, severe maternal morbidity shares a lot of commonalities with maternal mortality, but it's 100 times more common. And so that also has a lot of research benefit that we can conduct studies and ask questions that really the sample size is just too small for the most tragic outcome of maternal mortality. And severe maternal morbidity in the US has unfortunately been on the rise over the past couple of decades. This graph here is from some national data showing the rate of severe maternal morbidity per 10,000 live births, and it's steadily climbing. And this translates into approximately 60,000 people each year. And with a focus on children's health, this of course also has big implications for the health and well-being of infants and children. And even though I focus on data and I'm going to launch into a lot of large data, I do also like to remember and root that every one of these data points is a person. And actually, it's really been the stories of these people that have captivated attention to this public health issue in the past couple of years and really brought a lot of momentum that makes this an exciting time to make changes in this problem. So kind of overarching question that I've been very interested in, and a lot of people are very interested, is who is most affected by these severe maternal complications and why are they affected? And this figure here is from a CDC report using US data through 2007 to 2016, showing pregnancy-related deaths. And you can see that Black women and American Indian, Alaska Native women are at a relatively much higher risk of having a pregnancy-related death. And they wrote in this report that these differences in proportionate causes of death among Black and African American, Alaskan Native, women might reflect differences in access to care, quality of care, and prevalence of chronic diseases. And I've highlighted these three because those are really the areas that I've been focusing on. Is there's obviously a lot of factors going into what causes these inequities. And these are kind of three that I think in clinical medicine, there can really be an impact and change. So now I'm going to start to go through these study populations. I'm going to focus on the California birth cohort and the Optum Cliniformatics Data Mart, which David mentioned. And I'll also touch a little bit on Market Scan here. And then I'll also mention the Medicaid analytic extract. Probably several people are familiar with the California birth cohort. These are birth hospitalization discharge data, which are ICD diagnosis and procedure codes and a few other things. And they're linked to vital records or birth certificates and fetal death records, which contain a lot of sociodemographic variables and other factors of interest. And that's for all the hospital births in the state, which is approximately 500,000 births every year. This linked version of the data set was created by the California Office of Statewide Health Planning and Development and is available through 2012. Unfortunately, they stopped doing linkage at that time, and so more recent data are unlinked and available. And these data are available from OSHPD, that's what the department is called, upon request. And there's also a number of groups on campus who have acquired these data sets and developed them for their research purposes. Linkage to other types of data are possible with these California birth cohort, and they have been done for a number of very interesting factors, especially related to pediatric health. Social, they're linked to the American Community Survey and census tract data. Environmental, people have linked them to pollutants and air quality and a number of other related factors, and economics, such as the costs of hospitalization, provider fees, things like that. So if you're interested in more of what's going on, it's really a bunch of different groups on campus. I'd be happy to talk more. And also just to mention that California is a really special place to be able to do this kind of data and have this linked data, which does not exist for the country and in any other state nearly as large and diverse. And so this really, I think, makes the results that we can find from these data generalizable to studying pregnancy-related health. This graphic is just to emphasize that 1 in 8 births in the country is in California, and it's a much higher proportion of racially minoritized groups. All right, so I'm gonna just quickly, this is like some background information for an example I was gonna talk about in our studies of comorbidities, severe maternal morbidity, and disparities. So about a year ago, we worked on developing and validating an obstetric comorbidity scoring system. And basically this is a way to create a score for a given patient that adds up the weight of their comorbidities in predicting severe maternal morbidity. And the main purpose is as a method of risk adjustment for comparing hospitals with different case mix. And comorbidities here, I'm referring to conditions that would be present on admission for a birth hospitalization. And we considered 26 different comorbidities. These ranged from very rare but very high risk conditions such as placenta accreta and pulmonary hypertension down to much more common but lower risk conditions like gestational diabetes and high BMI. We created this scoring system using California data, and we validated it in a subset of that data. And then we also externally validated it in Optum, which is also just kind of an example about how we can be leveraging all these different data resources on campus to be performing studies. And then most recently, we worked on validating this scoring system in racial, ethnic, and socioeconomic groups. And the reason for that was that we purposely did not include race, ethnicity, or any other social factors in our scoring system for the purpose of trying to prevent embedding those characteristics in care decision-making or in risk adjustment. And so this part we were trying to validate if it had utility in these groups and then applying it within those groups as well. And what we found was that this risk adjustment for comorbidities explained these disparities for some group and masked them for others, which I'll show a little bit more on the next slide. So here you see these figures in panel A is groups by race, ethnicity, B, nativity, C, payment method for the delivery hospitalization, and then D, educational attainment, which also highlights the benefit of these linked data in California that we have very accurate overall data on these sociodemographic factors, which is not usually available in a lot of claims databases. And what we have on the y-axis is severe maternal morbidity per 10,000 births. Then the red bars on the left are what the SMM incidence is before standardization for comorbidity. And then the kind of gray bars are after standardization. And notably in the race ethnicity, we found that there was really some kind of dramatic changes. Notably, even before and after standardization for comorbidities, white patients had the lowest risk of SMM compared to all other groups of race ethnicity. After the adjustment, the rates decreased for American Indian, Black, and and Pacific Islander individuals. And I think that's to also reflect the importance of disparities in health before and during pregnancy and how those contribute to disparities during pregnancy outcomes and birth. And then interestingly, so Asian individuals and Latinx individuals actually have lower rates of comorbidities. So when you adjust for and standardize for these lower rates of comorbidities, their rate of SMM actually goes up in the disparity compared to white patients. And that's a kind of similar story to a lesser extent that we see by nativity, that patients who are foreign born actually had lower rates of comorbidities. So standardizing increases disparity. Same for patients on government program insurance, which is mostly Medicaid, that actually because of lower comorbidities, standardizing increased disparity. And then for education, we really didn't see much of effect at all of comorbidities, which is interesting in itself because there's clearly a gradient disparity for SMM by educational attainment, which is a strong proxy for socioeconomic status. So I mentioned quickly the Optum Data Mart, which David also mentioned, and I'm going to go into a bit about how we have used that and He's in this line of research. So Optum is a national claims database from 2007 kind of onward. I think the most recent year they're finishing is 2020. That'll be available soon. This is available from Stanford PHS, and it contains some sociodemographic information and healthcare variables, as well as diagnosis and procedure codes, ICD, CPT, DRG, for inpatient and outpatient healthcare encounters, as well as outpatient pharmaceutical dispensing information. So this makes it a really unique and powerful data set, in addition to its size, that, for instance, in the California data is only inpatient encounters, there's no pharmaceuticals. So this is, I think these different data resources have different pros and cons, and this is a big plus of Optum. And then he mentioned MarketScan, which also has a lot of similarities, but does not have sociodemographic information, and that's why we haven't used it as much for this particular line of research. But in both of those databases, we have applied a previously developed method to identify pregnancies, including live births, stillbirths, losses. And through that method, we have about 130,000 live births per year. And then I was going to just highlight kind of what my experience of 3 major strengths and 3 limitations of this Optum for doing perinatal research. A big strength is the large size. We're able to look at rare outcomes. Severe maternal morbidity is still at about 1.5% to 2%. So that's pretty rare. And especially if you want to look at subgroups to study inequities, you really need a large sample size. That's made possible through Optum or MarketScan too. As David was mentioning, these are pretty contemporary. I mean, through 2020, for such the size of the data is really powerful. They're national, and they have these data on outpatient encounters and pharmaceuticals that can really opens up the possibility of lots of questions that can be asked. A big limitation is that these are only commercially insured people. It lacks some key variables, especially for perinatal research, like parity and gestational age are reported well in the birth certificate, but not very well in claims. And in Optum, we cannot perform family linkages, though this is possible, and we've done it in MarketScan. So I was going to focus on this commercially insured people only. This has been a big barrier to my own use of this data, and I think other people as well. And it really highlighted a need in equity research to have Medicaid data. And the reason for this, especially in birth and children's health, is that Medicaid is a major funder. It's the largest payer for births. It's covering nearly half of all the 4 million births every year in the country. Medicaid coverage is universal in every state for low-income pregnant people. If someone's income is less than 133% of the federal poverty level, they qualify for Medicaid during pregnancy and through 60 days postpartum. This is also, these policies are a lot more inclusive in quite a number of states like California. And then the last point is that the majority of racially marginalized pregnant people are enrolled in Medicaid. Prior studies have shown approximately 65% of Black and 60% of Latinx individuals are enrolled in Medicaid during pregnancy versus 25% are enrolled with commercial insurance. Therefore, even though there's a lot of utility in the commercial insurance, focusing studies solely with that data set, those data sets are systematically excluding these groups of people who are also marginalized in many other ways. So that brings us to some exciting news about the Medicaid Analytic Extract, also known as MAX, which is the research version of Medicaid claims data created by the Centers for Medicaid and Medicare Services, CMS. So the Center for Population Health Sciences here at Stanford, with support of some various groups, is in the process of trying to acquire data for MAX for 2011, 2015, and 2018 with the hopes of expanding those to additional data years. These data are very similar to the commercial claims data sets in that they have some demographics and enrollment information, inpatient diagnoses and procedures, clinic visits, outpatient hospital encounters, outpatient pharmaceuticals dispensed, really a lot of information that can be useful for many, many research questions. And we anticipate, based on prior work, this will be about 320,000 live births in the initial 3 years of MAX data. And for our next steps, we recently had a pilot project funded by Stanford Spectrum PHS to focus on identifying clinical opportunities to advance equity in obstetric health using the Optum and MAX data. So that's where I really think there's a lot of excitement. And I think David was talking about the all pairs, which I just learned about and is even really also really exciting, but bringing these kind of groups together to answer research questions that are really generalizable to lots of groups of people. And this is just our initial study team, which includes a few departments here at Stanford, as well as a community partner with and so our project aims are, one, to focus on evaluating racial, ethnic, socioeconomic, and rural urban disparities in severe maternal morbidity in the US, and doing that independent of differences in underlying health at the time of birth. So leveraging these kind of medical and socio-demographic data and adjusting for this comorbidities. And the second part is to assess the contribution of differences in labor and delivery practices to disparities in severe maternal morbidity. As I kind of mentioned at the beginning, with this initial question about like, what can we do, and focusing on a clinical part of this to address inequities in maternal health, and focusing here on labor induction, delivery mode, and length of postpartum hospitalization, which we already know have large variations across hospitals and groups of patients. And then conducting comparisons between and also within socially marginalized groups. And so with that, I want to leave plenty of time for questions. Thank you so much for joining, and I hope this was helpful. Please feel free to reach out by email or any other way. And with that, I will stop my screen share.
Great. Thank you very much, David and Stephanie, for the great presentation and overview of the PHS data and the approaches you're taking. Well, I'll have the first question, but if you have any other questions to give to Stephanie and David, please put them in the Q&A section and I'll moderate that. It's on the lower right-hand corner of the screen. So while you're thinking of questions, I just also wanted to point out that the MCHRI has a huge health equity, number of health equity and programs for pilot funding. That includes the Structural Racism, Social Injustice, and Health Disparities Pilot Awards, the DRIVE program, which is the basically drive and research pipeline for underrepresented minorities in undergraduates, and also the health equity sessions at our upcoming fall symposium. So those are resources which are available through the MCHRI. But what I'd love to ask the question about is, in terms of the Medicare and Medicaid database versus Optum, what are the differences in the data set that come? In terms of, is it the same way to actually understand the comorbidities? Because you're trying to assess comorbidities at the time of diagnosis plus what's the effect of size on top of that. Is that the same for the Optum and as well as the Medicaid data set, or how do you standardize that?
Yeah, I don't know, David, if he knows more about this. So we haven't used the data yet because we haven't gotten it. It's in the process of getting acquired, but being familiar with other people's work who have used it and the descriptions of the data, it's very similar kinds of, you would certainly use, I'm sure there can be different variables and different data cleaning, but essentially the same information is there. These inpatient, outpatient diagnoses, procedures, pharmaceuticals, sociodemographics.
Yeah, very similar. And so in fact, in that EHR data I was talking about, there'll be within the medical records for a particular practice, there'll be people who have commercial and people who are on Medicaid. And, you see the same things in the EHR. The kind of behind the scenes thing to know is that the commercial claims data that we buy are very expensive, and Optum spends a lot of time cleaning that up. There's a lot more work, and CMS does a lot of work too on the Medicaid, but that's state specific, and there's a lot more sort of work behind the scenes on the Medicaid data to make it ready for research. So it's a little more time intensive for us to prepare and work with folks. And that also kind of varies by state as well. Yeah. But front facing, eventually, it's going to be useful for comparable questions.
That's awesome. I just want to thank you and the whole community, because clean data is useful data. And so data cleaning is absolutely critical for what we need to do. So thank you very much. Fernando has a question about how many of these data sets can be used to examine immigrants, particularly those that might be undocumented.
That is a great question. And the Medicaid data that Stanford's acquiring is being acquired initially by the Immigration Policy Lab. I mean, you may already know that, Fernando, but so they're certainly using it for those type of questions. But I'm not sure of the details, but I think it's going to be more based on some of the exposures that they're linking into that as well, rather than the type of documentation that's in the data. So that's actually a great question and something I'll look into more, because it's not super straightforward for most of these data sets, I guess I'll say.
I would just add that on birth certificates, people do write in the country they were born in. And I mean, you wouldn't know if they were documented or not, but
right.
You presume that's fairly accurate. And that's how we have grouped them.
Is there a way to connect that database with US Census data in any way to know if they're actually documented or not? I'm just trying to help Fernando. Like how to
there's all sorts of, this is kind of on so if people have those questions, it's great you bring it up, because it's on like kind of a case-by-case basis. And often there's a way to do it. It's just a question of how difficult and time-consuming it is. So for example, we're pursuing a number of projects where, because of the type of linkage we're doing, you have to go to the research data center at Stanford. So for example, we're linking individual level census data to some of this EHR data, things like that. So you'll go to the research data center, but then it becomes super high value, really interesting stuff, things that no one else can do. There's a few extra steps to get there, but if you have some of these questions that you're dedicated to, there's probably going to be a way we'll be able to figure out how to do it. So
sounds like we need to come talk to you. Is there a way then, in terms of identifying PHS data sets that have geographic identifiers, do all of them have those, or just particular data sets?
Yeah, and so not a great question. Thank you for that. Not all of them do. So that will be indicated, at our portal. So if you go into the data, read about the data. If we should have a tag for that. If we don't, we can definitely add that, because that's a really important tag. I think we probably have that. So start there, start looking through the data sets. And then if there's some data set that you're particularly interested in and you're not sure if there's a geographic tag, just shoot a question on Slack and the data team can answer that. Probably they're so fast, they'll answer that within within a day for sure, if not within 10 minutes. So
awesome. And then what about MAX? Is it representative of the US Medicaid data?
Yeah.
Go ahead, Stephanie.
Yeah, sorry, I was a representative of the US Medicaid. Okay, not Medicare. Yeah, I mean, as far as I know, it depends on the exact version that they're acquiring. As David was mentioning, is by state. And so different states do collect their Medicaid data differently. And then that all kind of goes to this one center in Minnesota that puts together this for research purposes. But it should be everybody enrolled in Medicaid.
Yeah, exactly. Yeah.
Great. And then you teased us a little bit with your last slide about the projects that you're doing. So there's a few people want to know about the last slide you had and the projects in terms of the exposures.
Yeah, great. And I'd be happy to talk offline too more about them. Basically, we're kind of wondering if we could try to disentangle where we could be investing a lot of effort, say, I'm involved with like California Maternal Quality Care Collaborative or CMQCC, and there's a lot of points and place that we could focus, having toolkits and interventions and around the time of delivery. And so we were focusing on how the disparities and some of those decision-making, maybe how people are induced or how when they have a cesarean or how those are contributing to disparities and then their ultimate health outcomes, and which groups are maybe being most affected by that.
Great. And then you can tell which groups have, due to the comorbidities that they come in with, or some independent graphic or whatever type of effect, right?
Yeah, exactly. As I'm sure everyone here is well aware, it's just really hard to, especially by hospitals, Stanford being a referral center versus centers that refer people out. It's really, there's a real need to at least just separate kind of pre-existing conditions from those that develop during a hospitalization.
Great. And then what about it in terms of like adverse childhood experiences. Can you ask that same kind of a question with the data set you have?
Yeah, so that's a great question. We're very interested in that as well at PHS. So the claims data, the EHR data will not have that sort of information in there. So that's where we can start to look at some of our other data sets that we host. And so I don't believe that we have any right now that have ACEs in them. But for example, I didn't get a chance to mention it, but we work with folks in the UK that have a Born in Bradford, which is a childhood birth cohort born in Bradford. And they have a lot of really unique data linkages to the educational system, to employment system, and spatially. So that would be the kind of thing that, you know, because it's sort of a smaller cohort with a lot of more richly linked in information, there may be opportunities there to link in information of ACEs if they were collected from a different, like the social welfare system in the UK. And so I can, if you want to reach out to me directly, I can see if there's that opportunity to have that sort of linkage for some of that UK data.
And I would just say in California, I do know there are some people in Southern California who have linked social welfare data to, I think, these California birth cohort data, and do this kind of work that I think you're referring to.
And then in terms of linking other databases, can you just describe, a lot of us are working on more molecular databases like SNPs and GWAS and that, or phenotypic databases for like, you know, birth defects, those sorts of things, or how do those things come together in your mind, and where can we then merge them in some way for the future? Yeah,
that's a great question. And if folks are interested in that, they should definitely reach out to me. I mean, if you notice that, so that IOM, the National Academy of Medicine report I put at the beginning, had all of those sort of things in there as part of real world data.
Right.
And so, you know, one of the data sets where we have them, so the commercial claims stuff where we buy it, like Optum and Truven, I mean, that's just sort of not possible. They have their product they're selling. I'm sure they're working on that. But there's things like the, you know, the data with the American Board of Family Medicine, where over time, there's sort of these possibilities become, they become more possible. So I would say right now, you know, the linkage with any molecular data is very limited, but it's, you know, it's definitely a direction where we're interested in.
Great. And then just a little bit more on real world data, in terms of how easy is it to do standardization or controls when it's just ongoing collection? Because it seems like it's a lot of data, but it's just being collected, you know, continuously and not necessarily in a with a hypothesis in mind. Mm-hmm. Is there a way to change the things that are being collected, or how much flexibility is there in the real world data type data sets?
Yeah, it's a great question, and you know, I mean, the answer is it depends. And so I think, again, it's similar to that last when there's these groups that we have a partnership and we're involved with, that we're kind of, you know, co-producing the research in a way. There's more of those kind of opportunities there. And then as other data streams come in, I mean, as I've done this kind of work really for the past 15 years, you know, it started out one kind of data stream, just claims. There's other things you can link in. I mean, the easiest thing right now is if there's spatial or temporal sort of differences in these exposures and they're geocoded, you know, really easy to link that stuff in over time. The census data, I have projects and we work on projects linking back to sort of early life exposures from historical census data. That's like pretty well worked out now. So, you know, every year there's kind of more and more we can start doing, and those become like excellent, you know, ideas for grants. As people have ideas, as there's something new they want to link in, a new type of data to bring in, those are sort of like even sort of the smaller sort of R21s for innovation. That's the stuff NIH would love to see, even in a really sort of exploratory way. So
great. Yeah, that's, I think for those on the call, this is really an opportunity for you to basically expand your own, you know, we think about sort of the bottom hypothesis generation, then you can test it by basically comparing it to these larger data sets. That's where you get a competitive advantage in your proposals. because it's not just a little system, it's basically now you have a whole database to compare it to. So I think that's really an amazing resource for us.
Yeah, and we see people, I mean, all the time with, you have a few, it's one of your aims. It doesn't have to be the whole proposal, but something that's really complementary to the work you're doing more mechanistically, and having that as another aim to expand it, to see how it plays out in some of this data. So
yeah. And then so for a typical last question we have on our noon seminar is, where would, for those that sort of might want to sort of donate or invest in trying to accelerate your work, where are the roadblocks that could be accelerated in the work that you're doing that would be most useful for you?
That's a great question. I mean, every one of these data sets take resources and time. And so, as I think, as Stephanie was mentioning, these excellent points about some of the Medicaid data, these all-payer claims data sets, some of those do require a little more like time to manage them. And so, going in that direction to support those data sets. And then I think the other thing is what I mentioned earlier, being able to bring in more sort of streams of data together and think about new ways to do that is another where we want to head. So
great. And is there one set of data base that you wish you could have that you haven't, that would be accelerated by a donor of some sort?
What you got into about some of this, I think some of the real-time data from, overlaying the wearable devices, sensors with some of the sort of claims data will really just get down. We have right now, the spatial stuff is so interesting. We're finding so many things, but if we're going to be able to get down to more resolution on some of the spatial exposures, more details to what people are exposed to in their everyday life, I think that's really just going to bring things forward in a long way. And there's ways to start doing that, but you're right, it does take an investment. So
great. That's amazing. Well, let's hope that can be done. I mean, I think we're the data, we're not going to be short of data. We're going to be short of the ways to analyze it and collect it and clean it up for our use. And so thanks for doing that. A great talk today, both from Dave Rehkopf and Stephanie Leonard. Please reach out to them and the PHS website. I think if you do, I think you will not regret it. So reach out, please. Thanks again, and we'll see you next month with the Spark group. Take care.
Thank you so much.
Great job, guys.
Thank you. Bye.